Lots of patients have a lot of fear by the time they show up in my office. There are still some patients that have the misperception that to have any kind of surgical intervention on their cancer is going to cause the cancer to spread. I'm kind of the specialist. I'm never the first cancer physician that a cancer patient sees generally. By the time sometimes they're seeing me, they've been maybe a little overwhelmed with what they've been told. Now we have medicines like immunotherapy that turns your body's own immune system on to attack cancer. Because it's your own body doing it, it's a heck of a lot less toxic. If it's done on the appropriate populations and we catch the cancer early, that's more important than having fancy tools to treat advanced disease later down the road.
Welcome to the Cancer Conversation Show, where we cut through the noise around cancer, the diagnoses, the treatment, the screenings, and the decisions that too many patients navigate without enough information. Dr. Meadows is a radiation oncologist with 19 years of practice in coastal Georgia. His approach is simple: lay it all down, give patients everything they need to know without the filter. If you or someone you love is navigating a cancer journey, this show is for you. Dr. Meadows, it's a pleasure to be here with you. Are you excited to get into this, episode 1?
Absolutely. Looking forward to it.
Awesome. So before we really get into it and get into cancer itself, I'd love to start with your story. So what originally drew you into radiation oncology, and what made you decide that this was the area of medicine that you really wanted to dedicate your career to?
I always tell people that I was very fortunate and kind of lucked into finding radiation oncology. Number one, I think it's the smallest specialty in medicine in terms of manpower and number of graduates that come out per year. It's not a required experience in medical school. So, many of my colleagues, including ones that I work with very closely, they say like, hey, I didn't have any exposure to radiation oncology. And people oftentimes ask me how I found it. Yeah, I was doing one of the required experiences in medical school, gynecology, and had to do a week on the gynecologic oncology service, which in a big academic hospital is where you would find those kinds of services there. Only on the service for a week and taking care of a cervix cancer patient in the operating room. And to my surprise, another doctor that wasn't the surgeon comes in, and it's the radiation oncologist. And he actually is putting an internal device inside of the woman to deliver radiation treatment directly to her cervix cancer, which I found very fascinating. And as a medical student who didn't really know anything, again, I'm assuming we're going to operate on this lady to get rid of her cancer, but no, it was this radiation. And so while he's doing the procedure, I'm the curious student. We start talking. And he's like, hey, why don't you, when you get done with all your required experiences, in the fourth year of medical school, at the very beginning, that's typically the time where you can choose some electives. And that was my very first elective, was radiation oncology. And once I, had that experience, it just caught on. And I was like, wow, I'm going to do this. And it was a real big departure for me because, I came into med school in the late 90s and the show ER was really, really popular. So emergency medicine, surgery, general surgery, anything doing with like trauma and emergency, that was kind of like the hot thing. So I thought I might want to do that. General surgery, that's a my experience with that's a really rough go, and I didn't want to honestly subject myself to that kind of lifestyle. And emergency medicine was my second choice, but radiation oncology still emerged as like the thing that I ultimately wanted to do.
We kind of hopped into your experience and why you got into radiation oncology and things like that. And I know you've been practicing. We talked about you practicing in coastal Georgia, but tell us a little bit more about yourself for our listeners, of maybe even what drove you to medical school in the first place before you decided on radiation oncology.
Yeah, well, definitely always had an interest in biology, chemistry. I was drawn to the natural sciences like that, and thinking about how to apply that. And, certainly medicine was something that started to emerge when I thought about, what do you do with a biology and a chemistry degree, a kind of deal. Unlike a lot of my colleagues, I'm not second generation medicine. I think something like 25% of doctors are second generation. Didn't have a particular experience with like, my pediatrician or a doctor growing up that kind of inspired me. But yeah, so it wasn't until maybe like sophomore year of undergrad when I really got serious and said, well, I think this medicine thing is what I want to do, more of almost like an intellectual, pursuit, and going to an undergraduate, like I went to Case Western Reserve University in Cleveland. It's big on producing a lot of doctors. So lots of undergrad chemistry and biology majors and folks going that route. So it almost seemed kind of natural. There were so many of my colleagues that or fellow students that were going that route too. But yeah, so that's what drew me to it. And again, went to med school in Cleveland from Youngstown, Ohio, old steel town that's seen better days, and did my residency at University of Florida in Gainesville, yeah, for radiation oncology after that.
And growing up, before you got into going to med school, were there any doctors or anyone in your family that practiced medicine at all?
No, definitely not. No doctors. I mean, I do remember, going to my pediatrician and whatnot. But again, it didn't at that time, it didn't spark any interest from a very, very young age. In Northeast Ohio, where I grew up, football and sports were a big thing. And I played football all through high school and even at the small college level. And certainly when I was growing up and more in the little league and all that, I had dreams of playing in the NFL, before going to med school, but, definitely glad I didn't go that route.
Absolutely. Well, you've been practicing for 19 years, so it sounds like you went to the route that really served you the best, and now you're able to help all these patients. And we'll talked a little bit about some of your patient experiences already. But is there anything else you think that is important for listeners to know, either about you or about why you're doing this podcast, and even anything to help listeners know more about you?
Well, the push for the podcast, number 1, I'm a huge podcast and social media consumer myself. This is something that I've said I've wanted to do for a while, have some degree of an online presence. It's just that, life's busy, it's another thing to take on. And I wanted to do it when I could be committed to at least putting out a certain amount of episodes. But, ultimately, it's to hopefully have some more impact. There's so many eyes out there online looking to consume content. Maybe somebody will see this and find it helpful in our local area or even beyond. If it sparks them to ask the right questions, if it helps them to get screened, if it takes away some fear about something related to cancer, then I feel that that's been a worthwhile endeavor.
I know many physicians tend to also have a defining moment early on in their career that kind of changes how they practice. So, was there ever a particular patient or an experience other than what you just touched on that maybe made you realize how much of the information gap between doctor and patient actually costs people?
Well, I mean, so to go back to one of the other kind of key things about like radiation oncology, I found that interacting with the patients, right, the level of like gratitude that they express to you for what you did for them, that was very attractive to me. There's a lot of my colleagues, and God bless them, they work in like hostile environments like the ER, where like even if you're the greatest doc in the world, sometimes that patient has been waiting hours to see you. That initial interaction is going to be kind of tough. You know what I mean? And with radiation oncology, oftentimes it's the exact opposite, and that really just appealed to me for the type of person that I am. I really enjoy those interactions. And then, I wanted to deal with sick patients, right? And so I think that was, in that same vein of like wanting to deal with what I thought was acutely ill patients, the ER folks and the surgery folks. Well, I still deal with very sick people who have serious problems, but it's in the ambulatory setting. It's very collegial with a lot of other colleagues that help me take care of these patients, and it's really intellectually, stimulating, and we use some very cool technology too. So, but if I had to go back to one core thing, it's really the how appreciative the patients are in this field.
Yeah, absolutely. I definitely could imagine it being so rewarding, and it's a lot of, I would assume, mental capacity too to be able to deal with people that are sick, but it must be kind of hard emotionally as well, but it's also sounds like it's very rewarding.
Oh, it definitely is. Yeah.
Absolutely. And we're jumped into talking about radiation oncology, but let's take a second because most people hear radiation oncologist and picture something vague or maybe even a little frightening. But in
Yeah.
plain terms, what do you actually do, and how does your role fit into a cancer patient's care team?
Yeah, well, broadly, there's three big areas of cancer care in terms of treatment modalities and the physicians that are in. There's surgery, which has been, the cornerstone of cancer care, stretching back for thousands of years. We have evidence of people doing surgery for tumors, way before radiation or chemotherapy was thought of. And then radiation came about right around 1900. They discovered that you could use x-rays to treat cancer. And then chemotherapy came along kind of in the 1960s. And surgery is dealing with local treatment of disease. Okay. Radiation kind of bridges that gap where we treat local disease, but also kind of regional disease if there's like spread a little bit beyond where the cancer started. And then my colleagues in medical oncology or chemotherapy, they deliver systemic, as we call it, treatments that go all throughout your body, your whole system to treat your cancer. So those are the three big disciplines: surgical, radiation, and medical oncology. And so the folks that I talk to on a daily basis for sure are in those specialties, but there's even a lot of other ones too. Some of my colleagues that do a lot of the diagnosing of cancers, like the pulmonologists, the lung doctors, and things of that nature. So, but broadly speaking, we are the kind of local, regional treatment specialists in the cancer care spectrum.
Got you. And something also with what you deal with on a regular basis is kind of why this show is built, right? So the show is built around a gap that you see every week in your clinic. So what do most cancer patients not know when they walk in, and what's the cost of that gap?
Yeah, it can be quite variable. I oftentimes tell folks that don't know about radiation, I say, I'm kind of the specialist. I'm never the first cancer physician that a cancer patient sees generally. I might be the second or even third, right? So by the time sometimes they're seeing me, honestly, they've been maybe a little overwhelmed in some instances with what they've been told, and even by the time they get to me, they still may have a little bit of a gap of like, how's everything kind of all fit together, right? So I do find myself trying to play quarterback, as it were, and get everyone on the same page and make the treatment plan, kind of obvious for the patient. Lots of patients have a lot of fear by the time they show up in my office. Some of them, they have horror stories. They've heard about people getting burned up by radiation or having really bad side effects and things of that nature, which in past eras, when we were using different techniques, the side effects were worse. So that can be true. We made tremendous progress in that regard, though. And so I'm often able to allay people's fears. It's always nice when people, depending on what I'm doing, your radiation treatment could be one day or it could be 7 weeks, right? And sometimes people come in the door with very different expectations of how long they're going to get their treatment, right? Honestly, most of the time I'm telling them longer than what they would want, but it's nice when I can tell them, hey, we can do this very quickly, not a lot of side effects and that kind of thing. It's always nice when you can kind of tell folks something less intense and less side effects than what they thought. So I do a lot of clarifying on those visits.
Absolutely, and I'm sure it is really scary for someone going into that, and like you said, you might not be the first person they speak to, so they've already had all these conversations and different information, and you mentioned it being overwhelming, and I think that, the internet is full of so much information, so much cancer information, and a lot of it isn't particularly true or it may be wrong. So, what do you think some of the most dangerous myths that you see patients walk in with? What does it really cost them?
Well, believe it or not, one of the ones that's persisted, and I had heard it from my family members from the time when I was young. So this is a really, really lengthy one. There are still some patients that have the misperception that to have any kind of surgical intervention on their cancer is going to cause the cancer to spread. Okay. I don't see it as much, but I still see it. And that's probably the number one most consistent myth that I've dealt with over the years. Most of the time, after some conversation, you're able to allay that fear and people proceed ahead with things. But every once in a while, I've had some people, not have the recommended surgery because of that, and things can go the wrong way. I've had some patients, they have a biopsy. The treatment of choice is to go undergo, multiple weeks of radiation, maybe with chemotherapy, and they are convinced that they have a holistic approach that may work for them. I've seen people take their own holistic concoctions. I've seen people who've had sufficient resources go out of the country and have alternative therapies done. And I've seen some real horror stories where their cancer, wound up progressing, and we wind up seeing them back. And sometimes we're able to help them after the fact, but sometimes we're not. So if I had to say two things, it's the cutting on it's going to cause it to spread, and I've got a holistic treatment method that's going to work over established care.
That's interesting because I'm not well versed in this area whatsoever, but I did recently watch a show, and one of the characters was a patient who had cancer, and it was an entire episode about her healing holistically and going out of the country to some other place to go to this retreat for holistic care, and it wound up not helping her in the long run. So it's sad that I just completely remember that experience. So I guess it is a lot more common than I would have even, assumed or thought. And with your experience, you've been practicing for 19 years, so I'm sure you've seen a whole bunch of these cases. So within the 19 years you've been practicing in coastal Georgia, a region that actually has a significant veteran population and patients who may be hours from a major cancer center. So, what about that has taught you something completely different? What does that community teach you that no textbook really could?
Well, you're right. Radiation oncology in particular, because it employs a lot of expensive technology and everything, most of the training programs are in major academic hospitals. Okay. And you have access to, again, the latest technology. You have access to really, really specialized surgeons and medical oncology colleagues, clinical trials, things of that nature. And when you come and practice in a smaller area, number one, you don't always have access to some of those, particularly surgical specialists, that when people really need a surgery that's, sometimes our local guys, they could do the surgery, but sometimes it's the aftercare that they need, the intensive ICU care and things of that nature. So they won't do the surgery here. And so we have to transfer them out. And a lot of times those patients will wind up coming back if they need, follow-up radiation and chemotherapy, but it's another extra step to go outside of the system. And there's even some times when I'm seeing a patient initially before they've had surgery, and I want them to go to a specialized place, and it's difficult. It does take some resources. So, for instance, Savannah and Jacksonville are about an hour away, and that's where we most often send people. Every once in a while, I might need somebody who have a really complicated orthopedic surgery or something, and they need to go up to like the Medical College of Georgia, which is several hours away, or Emory in Atlanta. And to just say that to somebody and have them be able to kind of pick up and do it, you realize, between the financial obligations, family obligations they have, and job, it's not always the easiest thing to do. So sometimes we wind up giving people, the best care that we can here to locally, recognizing that they just can't go out of town like that. So, and that's something that you just don't, you don't appreciate when you're in the ivory tower and you have access to everything. And when I was training at University of Florida in Gainesville, large university hospital, we had tons of people from the region coming to us, right? And so you kind of get skewed and think everybody that's supposed to come does come, but that's not the case at all.
Absolutely. Yeah, I could imagine that being really I live in New York City, so that's something that
Yeah, you get
I wouldn't have
access.
even thought about. You have those things so accessible to you, you don't really realize sometimes how lucky and fortunate you are to have such access close to you. I know you've described your approach to patients as laying it all down, giving them everything without the clinical filter. So, what does that look like in practice? And it sounds great. So, why don't more doctors do it, do you think?
Well, yeah, the number one, I think sometimes, it could be like a time crunch thing. It can be a situation where, maybe they know that, hey, I could go into the basics of it, but I know when they go see their medical oncologist or radiation oncologist, those guys will have time to kind of really go into it kind of deal. So I think those are probably a couple of the factors. So for me, we have these large screen monitors in the room there. And I'm a big multimedia guy. That's part of the push for me to like, start doing some of these podcasts and having a little social media presence. I digest so much of it, and I try to incorporate that into the patient visit. Number one, if there's any X-rays or anything like that to review with the patients, we put those up on screen. And a lot of times, patients will have had a diagnosis and they've been told what's going to happen and that kind of thing. But maybe they haven't had anyone like really go through their scans, and that's a big component. And like you say, a picture's worth 1,000 words. And sometimes just showing that to the patient so they can kind of see what's going on, that's very illuminating. And then I'll oftentimes pull up relevant, YouTube videos or some choice Google images that I kind of save that illustrates, how's the treatment going to go? What's a simulation, which is when we immobilize patients and take images of them to plan their radiation out? How does that actually look? I'll show some pictures of some expected side effects, like when I treat somebody for a head and neck cancer and I know their mouth's going to get some mouth sores and whatnot. I put that picture up so they can kind of see. And for better or for worse, I think it's always good for people to have that visual kind of expectation of what's going to happen. So that's a big component of what I do is pictures and videos in the exam room.
That's interesting. And I could see how it could kind of calm people down in the sense of not having as many surprises in a way. Like they kind of know what can happen for, like you said, for better or worse, like worst case or best case scenario kind of thing. So it's calming to them to not be as surprised. And so, for example, it's a first time patient appointment with you, and they come in with all these misconceptions or fears, as we kind of talked about, and you have the lay it down approach where you're kind of upfront and honest and with them. What do you usually do to help address their concerns beyond that in a way that actually helps them feel more grounded? I know you mentioned the visuals and things like that. Is there anything else that you help them with in making them feel grounded?
Well, I like to tell people up front too that, we're definitely going to be part of their follow-up team. I tell them how, I hope their whatever scan that has an abnormality on it, how things will look down the road. I oftentimes will tell them of patients that have had similar diagnoses to them that I'm seeing multiple years down the road and they're doing okay. So that I find that, I'm kind of laying out that roadmap of, hey, this is a long-term process here, and I hope to be seeing you down the road doing better. I tell them that up front too. Realistically, right? I mean, I see patients whose prognosis is very good. I see patients whose prognosis is not very good. And I try to be honest about things, but also instill some degree of hope though, for sure.
Absolutely. And being that you've been practicing for almost 20 years, in recent years, what are some of the biggest areas of progress or innovation in radiation oncology, whether it's technology or side effect reduction or maybe even treatment personalization? What's changed the game for patients compared to even maybe, let's say, 5 or 10 years ago?
Yeah, I mean, if I had to have a big theme of things, it is personalization of medicine and oncologic care and decreasing side effects and really kind of a molecular and genetic revolution going on that's changing how we do things. In the 19 years I've been practicing, I've seen us go from prescribing kind of standard regimens. Like for instance, when I got into the field, we gave 5 to 6 weeks of radiation for a breast cancer, no matter if the cancer was the size of a lemon or was the size of an apple seed, right? Like it didn't matter. We gave the same amount of radiation, and now we tailor things to now it's 3 weeks for cancers that are of a certain size, and then we also do these tests to see how biologically aggressive they are. And for some of the ones that are the least aggressive and small, the treatment is as short as 1 week now. Unheard of when I got into the field, right? And also, when I look at some like common malignancy, like a prostate cancer, again, kind of was giving everybody the same approach, 7 weeks of radiation. And now we can give the equivalent dose of that in 5 days with the right equipment, right? And checking the genetics of a prostate cancer to help us make decisions about, do they just need radiation? Do they need radiation and some other type of systemic therapy with it? So that's been humongous. So I would say treatment de-intensification that's guided by molecular genetics. That's a huge thing that's gone on in cancer care. For my medical oncology colleagues, we still use a lot of chemotherapy, and you can think of chemotherapy as sort of like a generic poison for cells. And it poisons the cancer for sure, but it also poisons a lot of other cells like your GI tract and hair and things of that nature. And while we still use it when it's possible, now we have medicines like called immunotherapy that turns your body's own immune system on to attack cancer. And because it's your own body doing it, it's a heck of a lot less toxic. And you can stay on this stuff for months and months and years at a time if it's working for you, right? So these are the type of things that are emerging. And another area that's going to eventually play a very big role that's emerging too in the surveillance of cancer care patients. Right now, we're still very heavily dependent on certain blood tests, say like a PSA for prostate cancer. That's a protein we can detect in the blood. That's very reliable for prostate cancer. We wish we had a blood test that could show cancer very early on for a lot of other cancers. And we're starting to get into this thing called circulating tumor DNA, where we're starting to pick up little tiny pieces of cancer in the blood. And sometimes we can detect a recurrence well before it would show up normally on a CAT scan or a PET scan or physical exam and that kind of thing. So that's another area that's emerging that's really going to change how we practice. It's very exciting. Hard to keep up with it all, to be
That's
honest.
interesting. No, that's innovative. I mean, it's great that that is progressing. If you really think about it quickly, within 5, 10 years, you see all these different changes.
And I would say the pace of acceleration is picking up too, right? And just in 19 years, it's a nice chunk to have been practicing. But yeah, the pace of change in the last 7 or 8 compared to like the first 10 to 12 that I've been practicing, it's going faster. Yeah.
And for someone who's listening right now who has a nagging worry or a symptom that they've maybe been ignoring or putting off, a screening they've been putting off, what's the most important thing that they should do this week?
Well, I can't emphasize enough screening. And, I look forward to, further conversations, further podcasts that we'll have where we can get into some details with that. But when you look at the impact on survival overall when it comes to cancer care, it's very cool to tout the new technologies and everything, and they're fascinating and they're great and everything, and they have improved things. But when you actually look at impact in terms of lives saved, screening, a lot of times pretty low tech stuff or whatever. But if it's done on the appropriate populations and we catch the cancer early, that's more important than having fancy tools to treat advanced disease later down the road. So I would say definitely get screened. It's much, much easier to deal with an early caught cancer in any arena.
Absolutely. I would imagine, like what you said, the earlier the better. Early detection is definitely, I think, key. Are there, before we kind of wrap up, and I have another few questions, but is there anything that you want to add on that you want listeners to hear? Any thoughts or anything you think is important to add to the conversation?
I just want to, and again, we'll talk in some more detail about screening and everything. When I look at the rates of screening for certain things, I mean, we could certainly do a lot better. I've read some estimates that maybe the percentage of women that are eligible to get their mammograms that actually get them, it may be, I don't want to misquote it, but maybe as many as a third of women don't get their mammograms as they're supposed to. And I got to look up the numbers on lung cancer screening, but I know that that's not being done nearly as much as we would want. So that's a real big push, I would say, because that has the most impact. So just extra shout out for screening.
Absolutely. And I think even knock on wood, I'm fairly healthy and I know people that are healthy and I know people who have had cancer. And it's one of those things that even if you're healthy, those things are a little bit uncomfortable or a little scary. So people do tend to push them off, like, so it's good to bring awareness and have this conversation because I think sometimes when you are, like, let's say a healthy person, you kind of think, oh, I may not need that or, oh, I'm fine. And it is a mentality that is common, but that's why these conversations are so important because people think things can't happen to them until it does a lot of the time. So it's important to be proactive.
Oh, absolutely. And, put a little extra shout out to the gentleman in the audience listening to this. It's well documented. Women access the healthcare system on the preventative side with like screenings and things of that nature significantly more than men. And so, I see that reflected in my practice in terms of, seeing that a little bit of a gender divide on like, the folks that come in a little bit more advanced disease and stuff like that. They do tend to be the guys, and so, extra shout out for you gentlemen, go to the doctor, get screened, do your preventative care, big time.
Last question before we close out this first episode, and I think this one will close every episode of the show. But what do you want someone who was just diagnosed or who loves someone who was just diagnosed to know right now, today, before they even know what questions to ask or where to start asking questions?
Well, just diagnosed with cancer, we're in an information age and everything. I don't mind patients. Number one, they should have a conversation with the physician, that diagnosed them and ask some basic questions. I'm finding more and more, I don't mind that patients do a little internet research and at least get some basics in their mind too. Even if some of it's a little off, I don't mind correcting it, but I like seeing patients take a little bit of ownership and agency in trying to understand what's going on with them.
Absolutely. I think this was a great first episode to a lot of other conversations to come and a first great episode. And for anyone listening, if you've ever left a doctor's appointment with more questions than answers, this show is for you. And make sure that you follow so you don't miss what's coming. And if you know someone navigating a cancer diagnosis, consider sharing this episode with them. And thank you so much, Dr. Meadows. I'm excited for the episodes to come and to continue the conversation. And for everyone listening, thank you for listening to the Cancer Conversations podcast. Stay tuned. There's so much good information coming. Make sure you follow and share and subscribe. And Dr. Meadows, it was such a pleasure, and I cannot wait to speak with you soon.
All right. You have a good one.